And thank you for calling this hearing. I truly thank our witnesses today for their knowledge and for their willingness to be here to share with us their information. In about 2 weeks, our nation will mark the 4th anniversary of the enactment of the Affordable Care Act, better known to most as Obamacare. Today's hearing will inform what direction we will next take health care in America by examining access to care and cost associated with health care systems overseas. As we examine single-payer systems in other countries and what we can learn from their experiences, it seems fitting that we also take stock of where things stand in the American healthcare system today. At the time Obamacare was being debated in this very committee, I warned that it was the wrong direction for our country. Healthcare was broken before Obamacare, but 4 years later, the American people are experiencing firsthand how the new law has made things worse. That's why Americans view the law unfavorably, and that's why they are understandably wary of still more government involvement in healthcare. The President promised that if you like your plan, you get to keep it under Obamacare. The federal government mandates that Americans buy health care coverage, and not just any coverage, but the coverage the federal government says is good enough. Sadly, millions of Americans have lost their health care plans, health plans they liked and wanted to keep, despite the promises and continued delays of the administration. Obamacare expanded Medicaid, an unsustainable health entitlement program in which 40% of physicians on average do not even agree to see Medicaid patients. I believe the experiences of other countries will reinforce what many Medicaid patients already know. Their coverage does not always translate into timely access to care. Today's hearing will also examine cost. While the President promised that Obamacare would bring down premiums by $2,500, premiums have actually gone up by an average of 41% in the individual market due to the law's mandates. So, how does Obamacare attempt to control cost? For starters, it established the Independent Payment Advisory Board, or IPAB, an unelected, unaccountable board of 15 bureaucrats empowered to make cuts to the Medicare program, most likely in the form of cuts to doctors, which will impact, again, seniors' access to care. Today's hearing will be informative as to the direction we take health care in this country. Will we repeal Obamacare and replace it with reforms that lower health care costs, put our nation's entitlement programs on a sustainable path, and empower patients in their health care purchasing and decision-making to find the plans that best meet their individual needs? Or will we continue on the current course of unprecedented government involvement in health care and unsustainable costs? What do we have to learn from a single-payer system overseas, and what have other countries' reforms meant for their patients? What would such a course mean for our nation standing as a global leader in medical innovation and for American patients seeking access to quality and affordable coverage and care that meets their individual health care needs? I do want to thank Chairman Sanders for holding this hearing because it will inform many of us on these important questions. I think today's hearing represents an important admission that Obamacare is not working, that such an admission takes place within the very committee that the act was written in is a huge step, and I commend the committee for taking it. I look forward to hearing from our witnesses today and continuing to work with my colleagues to advance patient-centered reforms that will actually lower health care costs and increase access to quality, affordable health care. I thank Dr. Martin, in your testimony, you note that Canadian doctors exiting the public system for the private sector has had the effect of increasing waiting lists for patients seeking public health care. Why are doctors exiting the public system in Canada?
Thank you for your question, Senator. If I didn't express myself in a way that to make myself understood, I apologize. There are no doctors exiting the public system in Canada. And in fact, we see a net influx of physicians from the United States into the Canadian system over the last number of years. What I did say was that the solution to the wait time challenge that we have in Canada, which we do have a difficult time with waits for elective medical procedures, does not lie in moving away from our single-payer system towards a multi-payer system. And that's borne out by the experience of Australia. So Australia used to have a single-tier system, and in the 1990s moved to a multiple payer system where private insurance was permitted. And a very well-known study by Duckett et al. Tracked what took place in terms of wait times in Australia as the multi-payer system was put in place. And what they found was, in those areas of Australia where private insurance was being taken up and utilized, waits in the public system became longer.
What do you say to an elected official who goes to Florida and not the Canadian system to have a heart valve replaced?
It's actually interesting because, in fact, the people who are the pioneers of that particular surgery, which Premier Williams had, and had the best health outcomes in the world for that surgery, are in Toronto at the Peter Monk Cardiac Centre, just down the street from where I work. So what I say is that sometimes people have a perception. And I believe that actually this is fueled in part by media discourse, that going to where you pay more for something, that necessarily makes it better, but it's not actually borne out by the evidence on outcomes from that cardiac surgery or any other.
One would believe the American people prefer their system because they know consciously they pay more. No, I think it's because they judge quality and they judge innovation. Ms. Pipes, in your testimony, you noted that more than 42,000 Canadians come to the United States each year for health care. Why is that?
Because they find that they're on a waiting list in Canada for too long a period, and they feel that their health is at stake. So a lot of people in Canada come to the U.S. for MRIs, CT scans. There are many examples in the media of people like Brian McCreath, who came to the U.S. because he was told by his primary care doctor that he might have a brain tumor, but the wait for an MRI was very long. He spent the $1,000, came to the U.S., paid out of pocket. You will see advertisements in Canadian newspapers for MRIs, for neurosurgery.
It's a pretty fertile ground to market in.
Right.
Dr. Martin, in your testimony, you state that the focus should be on reducing waiting times in a way that's equitable for all. What length of time do you consider to be equitable when waiting for care?
Well, in fact, the Wait Time Alliance in Canada, sir, has established benchmarks across a variety of different diagnoses for what's a reasonable period to wait. And what we've found is that actually working within the single payer system, we can reorganize things. You know, I waited more than 30 minutes at the security line to get into this building today. And when I arrived in the lobby, I noticed across the hall that there was a second entry point with no lineup whatsoever. Sometimes it's not actually about the amount of resources that you have, but rather about how you organize people in order to use your queues most effectively. And that's what we're working to do, because we believe that when you try to address wait times, you should do it in a way that benefits everyone, not just people who can afford to pay.
On average, how many Canadian patients on a waiting list die each year? Do you know?
I don't, sir, but I know that there are 45,000 in America who die waiting because they don't have insurance at all.
Well, let me go back to Dr. Rodwin's statement. The American system has access to health care for everybody. It's called the emergency room. Now, we don't admit that clearly because we're lobbying for a particular angle. But every American can access health care. They can access primary care. And Dr. Rodwin, I would agree with you that we ought to make sure that there's a medical home for practically everybody we can place. We don't do it in Medicaid. We should. States should adopt it because primary care is an absolute necessity to wellness. But Mr. Kjellberg, how many Danish citizens have supplemental health insurance policies, and why has that number been increasing in recent years?
About half the population got co-payment insurance, and that have increased dramatically over the last year because your family were included, so children were included, and that brought up the numbers quite significantly. But the number for policyholders haven't really changed much.
But half the population has supplemental insurance.
Co-payment insurance. And then many people in the labor market also, as part of a benefit package, are offered health insurance so you can have faster access to elective care.
So they can actually buy their way to faster access.
Oh, you can buy that. There are private hospitals. You can buy any hospital services in Denmark.
So they have options. They have choices.
They have choice, yeah.
Dr. Rodwin, in your testimony, you note that Parliament sets healthcare expenditure targets each year. If a hospital or a physician exceeds their target expenditure by billing for higher than projected volume of services, prices are negotiated downward for the following year. Beyond volume or utilization of services, are there quality metrics that the French use to determine reimbursement for physicians or other providers in order to incentivize quality care for patients? For example, measuring health outcomes to ensure patients are receiving quality care.
Well, this is a science that's not well developed neither in our country nor in France, but they are working on this very question, which is very timely right now. That is, the negotiations focus certainly on volume, but now there's a program called IFAC, which will remunerate physicians. Well, that's actually already in place if they follow certain standards of preventive care.
But they're penalized if they bill at a higher rate one year. They're penalized in the next year by a reduction
No,
in
that's
the reimbursement.
every year, sir. There's a negotiation to set these rates, and if the volume goes up, then the
rates,
following year the
reimbursement
prices.
go down.
That's the practice. It's the volume health performance standard.
Thank you, Doctor.
Yes, it's a
Thank you, Mr. Chairman.
budget target.
Senator Burr.
Thank you, Mr. Chairman. Let me say before I ask the second round of questions, there's been a lot of reference to Medicare and single-payer system. Let me just remind everybody, in Medicare, for a working lifetime, I pay into a system to finance part. There is a government share. When I become a senior, and I go and get Part B coverage, which is the physician side, I pay a premium for that. When I go to get drug coverage, I pay a premium for that. You can't look at Medicare and say this is like the single-payer system in Taiwan, where the government picks up the entire tab. Now, healthcare is not free. We all know that. It comes out of general taxes. But there's a difference for seniors in America that they are personally invested into a system, and they even have choices. They can choose a Medicare Advantage, which is a private sector coverage. At least they could before Obamacare, and now that's getting knocked out. And they can choose as a senior to buy Medigap insurance, so they can buy their way out of skin in the game. The one thing that I heard is that everybody, except for possibly Taiwan, has some degree of copay. France does, Canada doesn't. But they do as it relates to drugs because they're on their own for drugs. And what I want to talk about is drugs because Ms. Chen, Dr. Yu, our friend from Taiwan, said in his testimony that patients in Taiwan can experience delays in coverage for new drugs and new technologies from 2 to 5 years from adoption of the United States in that. And Ms. Chen, you touched on prescription drug prices in your testimony. Almost all countries enjoy the benefits of America's medical research and development, but developed countries don't pay their fair share for the immense expense involved in the development of innovative life-saving therapies. These countries are free riders on the United States by enacting price controls on drugs and devices. How would sharing more of the financial burden that comes with research development of life-saving drugs and devices affect comparison between the United States and the countries we're discussing today? That's to you, Ms. Chen.
Thank you for this question. First of all, yes, United States does fund a whole lot of R&D in pharmaceutical and other device innovations. But in so doing, we are also helping to make the American healthcare system that much more expensive. In fact, so expensive that we're pricing people out of the healthcare altogether. So United States is you know, so in terms of R&D in single-payer systems, I think it is the governments of these systems can set aside specific R&D funds to help with R&D for innovations.
Ms. Chen, in the U.S. system, when we shifted from exclusively doing bypass surgery for heart blockage,
right.
And we went to catheterization because innovation allowed us, or technology allowed us to do catheterization. Do you consider that to be a cost savings to the United States or the expense of a new innovation?
if it is done on the right patients at the right time, yes, it is a cost-saving innovation and application of that innovation. However, I think with United States healthcare, there's a very serious issue which has not been addressed, which is overuse of services. We have here in my testimony, there's
But in that the risk of letting the American people choose healthcare and having a marketplace versus having government dictate what, where, when, and how much?
It's not a matter of letting people decide in the marketplace where to go or what to choose, what to have.
We overprescribe grossly pharmaceuticals in the United States. Why? Because the American patient has the right to go in and ask their doctor, and because of our liability exposure, the doctor feels compelled to write the script in the United States. And I would tell you that's a lot of the healthcare, a lot of the drug costs. Let me just move.
May I just say
Yes,
this? In a Institute of Medicine book, in fact, I brought it, it says that this overuse of everything, services, devices, drugs, it causes waste in the American health system. According to this Institute of Medicine book, about 1/3 of U.S. healthcare is waste, and $750 billion a year. And of that, unnecessary services accounts for $210 billion of the $750
I wouldn't
billion.
disagree with the conclusion of that. I have one last question, Mr. Chairman, and it's to Dr. Holberg. In contrast to what I've just talked about with Ms. Chin, price controls overseas don't reward innovation. If the United States were to follow the price control model, what would happen to patients' access to innovative treatments here in America as well as overseas?
In the long run, you would see less access to new innovative drugs. It'd be that simple.
So if in fact we eliminated innovation, in many cases that innovation which takes somebody out of a hospital setting, puts them in an outpatient facility, they're treated, they no longer have the risk of infection because of inpatient, they no longer have the days in the hospital. That's not only been beneficial to the cost in healthcare, it's actually beneficial to the quality of the outcome.
Well, sure. Frank Lichtenberg's looked at this extensively, and he's estimated that for about every dollar we put into pharmaceuticals, you save well over $3 in hospital costs by avoiding hospitalizations. The price controls can have one of two impacts. If you have a price control that's lower than the market price, you'll see a shortage. If it's above the market price, you'll see a sorry, I'm losing my train of thought here. You'll see a surplus, and that's kind of what you're going to end up with, a system of price controls.
I thank you. I thank our witnesses. I would ask the chairman for unanimous consent to allow us to submit questions to all the witnesses for the purposes of the record.